Hey, Susie.
See. Can you hear me?
Hey, Susie. Yeah, I can hear you. How are you?
I'm good. How are you?
I'm doing great. I'm going to make you a co-host
Oh,
so
geez.
you can share your slides. So I'm just admitting Joanna. What we're going to do is kind of wait till closer to 2 o'clock to get going here. And thank you again for, presenting this to school nurses.
My pleasure.
We appreciate it. Can you hear me okay?
Yeah, I can. Can you hear me?
Yes, yeah. I do need to turn my sound up. I just came from a DOE meeting and I had to turn the volume down. It was pretty loud. So I'm
How
at
many
my
people?
mom's right now. Hey, Joanna.
Hey, Tracy. Hey, Susie.
Hey, Joanna, how are you?
Doing well, thanks. Do we need to kind of get you up and do a quickie thing before I have to let people in to make sure your screen's looking good, or you feel pretty confident?
We can try that. Oh, okay. See, now where am I?
I just want you to be happy.
I do too. Thank you. All right, now I've lost you guys.
Okay, maybe because I need to pull my screen up too as well.
All right, I see you. No. Okay.
I mean, I could try to run her presentation. She could just say next slide, next
Okay,
slide if
that's
you want me to. So can you make me a host?
I did. I made you a co-host. Yeah.
Okay, so I already am?
Yep.
All right, let me see if I can, all right. Let me see if I can get my screen shared for you. So hold on one second.
Rock stars.
We try.
So yeah, I have like 30 slides, but honestly, the last 5 are just like resource pictures, like,
Okay.
Visual. So how quickly you want me to go? Like, you got a big agenda.
Yeah.
The agenda scares me.
Nah.
Let's see. Can you do it like 45 minutes or so, or?
Oh yeah. Oh yeah.
Okay.
I'm not going to beleaguer it. Nope.
Okay. I think
Can
there's
you
going
see
to be.
this? Oh, sorry.
Go ahead.
Can you see the screen? I just want to make sure you can see it. Does it look good?
I can. It's just not in presentation mode, right? Because it's got all the slides on the side.
Okay, let me see if I can flip you to presentation mode.
So you probably do enable editing, maybe? I don't know.
Let's try it and see.
And then up on the top, it says view, or it says slideshow, I think. See there? Yeah. Boom. And from beginning, all the way on the left. That's it.
Okay.
Then when you click that.
Ah, there we go.
Yeah.
Yeah.
Let me just, can we stop? I just want to be sure I can pull mine up too. So I'm just going to stop sharing for a minute.
Okay.
And,
All right, so you want me to stop sharing?
oh, I just pushed stop sharing and I wanted to, that's not what I want, but anyway, can you see my screen?
Yeah. I see your files, desktop.
Yeah. It's a messy desktop.
Oh no, all of us.
What do I do with my, okay, let me just go to Google Word document. I don't know why it's not coming up.
Tracy, do you want me to share my screen for that too? You want me just to be the screen share?
I got it.
Oh, okay.
Let's see if it'll come up. Let's share. Hold on. I guess I just didn't do this correctly. Can you see it now? Can you see the agenda?
We have like a blank screen. There's no agenda on it.
Okay.
It's like a blank Microsoft sheet.
Okay, I got it right here.
Yeah, there you go.
Okay,
Surprise.
all right. So, okay. We're gonna, Susie, before, we're gonna start letting people on in, but, I just wanna, we have a bunch of, we have several school nurse coordinators who are new. And so we want to welcome them and have them unmute themselves and introduce themselves.
Yeah.
So, oh, you look good.
I was like, where is my face? I just see my name. Love your glasses.
You know, they're my readers, you know.
Yeah, so are they.
So I'm at my mom's. I'm in the back room.
Yeah.
So the lighting is a little different. And so.
Well, yeah, I'll be on standby. I'm here for you guys. You pull me in.
Oh, you're
pull me
great.
out.
And
Whatever.
maybe we can talk. I got an email about antigen testing.
Mhm.
And so I know that there's been some, I know that we've been told that there's been some antigen testing units allowed for schools.
Mhm.
And I don't know that I want to get into that today. Frankly, I don't know how we're going to operationalize that
Right.
in a school setting, but I've been asked to comment to our policy folks about that. So perhaps we can talk about it at another time and just see.
Well, I have like 2 slides on it. Basically,
Okay.
it addresses the news that
Okay.
HHS was sending Binax Now cards, and schools are a priority. And then the next statement is our Commonwealth antigen testing team is reviewing that right now. And so we don't have the operation, but it's being worked on. Done.
So is this a saliva or is this
No.
a swab?
It is a swab. I have two pictures that will
Okay.
show the 2 different kinds. And I was just going to briefly go over it, but the saliva hasn't
Yeah.
panned out.
Okay.
It's not
All righty.
successful.
Okay. I just don't want to freak nurses out right now. Anyway,
No, I hear
so I would just want you to see my shirt. I don't know if you can see it.
Ah,
Today
is
is the day.
it is. Isn't that every day?
I know. It is so hot in my mother's apartment because she gets cold and she's 93. And so I opened the window up and I put a t-shirt on just because I'm sweating. So anyway, so Joanna, I think we can look at the waiting room and we can
We got
let
8.
people, I'm
we
going to
got-
go ahead and admit everybody.
Okay, you want to? All right.
I just admitted everybody.
Perfect. I can take over if you want me to,
Okay,
or we
that's
can just
great.
click, just whatever you want to do.
That's great. If you want to take over, that's great. Fabulous.
I'll stand by.
Are we recording this? Let's see. We want to record this in the cloud.
Hello.
Okay. Okay, we are recording it. The last time I recorded, it was to the computer instead of the cloud, and I couldn't download it. It was too big of a file, even compressed.
Yes, you have. Yes, you have. Yes.
Hey, Glory, how you doing?
I'm good, Tracy. How are you?
Well, we're all hanging in there, trying to.
Amen. I sent
Trying to.
you an email saying I couldn't get in, but I ended up using your earlier email and got in. So
Oh, huh.
the one with on the attachment wasn't letting me in. So
It wasn't, huh.
yeah.
Okay, maybe that's why we don't have, let me just look at my phone.
Yeah, the one that you sent that was directly in your email, that one I got in,
Okay,
but the attachment one, it wouldn't let me in. It said it was an invalid ID.
huh. Okay, a lot of people are getting that, so let me,
Resend it in just a direct email. That
Yeah,
was how I
okay.
got in.
okay,
Thanks.
all right. I wanna minimize this. Hey, Joanna,
Yes, Tracy. Yes.
is that something you can do? Can you go ahead and,
Do you want me to resend the email
could you
out to?
resend the link, the Zoom link?
I'll be more than glad to. So it's going to cause me to pop off. So you'll have to let everybody in.
Okay, I'm letting everybody in.
Okay.
Sorry about that, everybody. Okay. Okay, we're just going to give it a few more minutes. Is that Dr. Javarius on the line too? Awesome. Awesome, great. Hey, good afternoon, school nurse coordinators in Virginia Public Schools. My name is Tracy White, and I am the Virginia Department of Education Schoolhouse Specialist. And we're going to give it a few extra minutes because apparently the link that I had sent wasn't working for some folks. So we're sending it out again. And it's a very exclusive group. I know, sometimes you feel a little more exclusive than you want to be, don't you? Hey, Maisie, how you doing?
Doing good. How are you doing?
Very good. This is going to be a smaller group than our meetings on Thursdays. And so please feel free to use the chat box if you have a question or unmute yourself. We're going to go ahead. Joanna, are you back on by any chance? Not sure if Joanna's back on. We'll just give her a few more minutes. So I know this is in the middle of the day for a lot of you in the middle of the afternoon, but it's kind of hard with people having different schedules to get everybody where they can come. Some of you have to be out of the building at a certain point of the day, and so we just try to do it the best way we can. We are recording this meeting, so I will be sending it along with a revised agenda and any other slides. We will be sending them on out tomorrow. So hopefully you'll get that link. And okay, I'm just hearing some messages. Okay, so while we're waiting for Joanna to pop on the line again. Joanna is my colleague at the Virginia Department of Health. And many of you remember Janet Wright, who was the school nurse specialist for over 10 years. Go ahead and mute your lines if you would. That'd be helpful. Yeah, we had really great opportunities to work with a great collaborative team from the Virginia Department of Health and from the Virginia Department of Education. And so when Janet retired over 2 years ago, there was a huge gap at the Virginia Department of Health. And it wasn't for lack of trying. We had 7 different interview panels until we found the right one in Joanna Pitts. And Joanna is a school nurse. She was a school nurse in Henrico before joining the team at the Virginia Department of Health as my counterpart there. And so it is wonderful, as you all know, because many of you are isolated in your localities, to have a partner to work with. So it's fabulous. So anyway, so I just want to welcome you to the meeting. It's 2:05 and I want to go ahead and get started. I want to welcome you to the meeting today of school nurse coordinators. And you are the key folks within your school division. And many of you, most of you are returning, but I want to recognize and give a few minutes for those of you that are new to your position to go ahead and unmute yourself and tell us your name and what school division you're with, and just kind of say hi. This is a real informal group. So Elizabeth, do you want to kick us off? Elizabeth and Nelson? It's an easy name to remember. Elizabeth Taylor. Go ahead and unmute yourself, Elizabeth.
Hello there.
Okay.
I believe pretty much for me. I'm Elizabeth Taylor, and I'm now coordinating Nelson County nurses.
Okay,
Good to be
great.
here.
Thank you very much. And who retired in Nelson?
Peggy Swan.
Peggy Swan. Right. So most of you, many of you may know Peggy Swan. And so Nelson County is in the Piedmont area of Virginia, the Thomas Jefferson Health District. And so Elizabeth, it's good to have you on board. Who else would like to unmute themselves? I see Courtney.
Yes. Hi, from Rappahannock County Elementary and High School.
Okay, Courtney Atkins.
Yes.
Thank you. And Rappahannock is up west of Culpeper. Is it north of Culpeper? Okay. All right, thank you. Replacing Linda Torrance. Who else is new? Would you please unmute yourself?
Hey, I'm Anna Haymaker. I'm here in the city of Salem, and I'm the new coordinator here.
Great, great. Thank you very much. Welcome, Anna.
Thank you.
Okay. Anybody else? I see. Okay.
Robin Murray.
Robin Murray. Okay.
And I am,
You're
sorry,
getting a lot of bounce back. Is your phone near your,
hold on just a moment.
there you go. Now you're muted, Robin.
Sorry, I was trying to change it here.
Yeah, put your phone further away from your computer. Yeah. Okay. We'll come back to you, Robin. Okay, we'll come back to you. Okay, who else is new?
Shatera Robertson. I'm with Warrensville City Public Schools.
Can you repeat that again?
My name is Shatera Robertson. I'm with Warrensville City Public Schools.
Wonderful. Okay. We've got a new crop here.
Hi,
Okay.
it's Star.
Hey,
Wilson
Star.
in Portsmouth. I'm having a lot of computer issues in Portsmouth, but I'm here.
Star is not new to school nursing, but she is new to Portsmouth, right? Is that correct?
Yeah. Yeah.
Yeah. And for those of you that are not aware, there's a VPN issue and some issues with the servers at the state level. So anyway, okay. Who else is new? Robin, you want to go ahead and try it again? Robin Murray?
Yes, I'll try again. I'm Robin Murray, and I'm at the Rappahannock County Elementary School with Courtney Atkins.
Great. Okay, you're tag teaming. Wonderful.
Yeah.
Welcome.
Thank you.
All right, who else?
Hi, I'm Sarah Carlton. I'm with Hanover County with Terry Woody.
All right, thank you. Is Terry going to be on the call today? Is she able to?
Yes, she's here.
Okay, great.
I am
Wonderful.
here. Hi.
Hey, Terry.
Hi.
You've been in the news lately.
We're always in the news, but everything is good. I want to report in Hanover County. We are good.
Good, wonderful. For many of you, I ask you to bring a emerging leader. For those of you that have been in acting as school nurse coordinators or health directors for your school division, I've asked you to invite an emerging leader within your school division. It's important. We know that as we move forward, not only with in-school health, but to address the changing needs, we need strong leadership in our school divisions in the health area. So we really need to tap and really need to kind of model and cultivate leaders within our school divisions. And school nurses always have proven themselves over and over again. And so I just want to thank you all for being here. Is there anyone else that would like to introduce yourself?
I'm Paula Nichols. I'm the new head nurse for Washington County Public Schools in Southwest Virginia.
Oh, great. It's great to meet you. And you took over from Rachel Morgan, who retired, correct?
Yes, yes.
Wonderful. Hey, I saw that video you did earlier this summer.
Yes.
That was great. I've seen a number of the products that have come out of Washington County, and they're just terrific. So, all right, thank you. Anyone else? I'm seeing so many new faces here. It's wonderful. Traditionally, we hold our school nurse coordinator meetings on a quarterly basis, face-to-face. They've been in Charlottesville for the last year or so. And so we're going to be doing this for a while, most likely for the entire year, as our travel, in-person travel and overnighting, our budgets are limited, and due to COVID issues, at least it doesn't blow your whole day. We're taking a whole day, what would normally be a whole day professional development, and condensing it into 2 hours. So if there are questions that are remaining after this meeting, please put them in the chat and I will address them, and along with Joanna tomorrow when we send a recording, Zoom recording of the meeting and an updated agenda, we'll address those questions. So many of you have been a part of the weekly Zoom meetings that took place beginning in March. I will say that no one was more surprised than I was when we started off with maybe 70 people in the meeting and have ended up with close to 500 people during these weekly Zoom meetings. The meetings are now every 2 weeks. We have one coming on Thursday. So please encourage your school nurses, if they're not part of the school nurse listserv, you can send them the information to join. I get numerous requests to please add me to the listserv, please add me to the listserv. There's over 1,000 people that are on the listserv right now, which is wonderful. But I can't keep doing this manually. So we set up a Survey Monkey. It is the link to the school nurse listserv is on Padlet. It's also underneath the email signature on my email line. So anyway, I'm glad to have you here. Please encourage your nurses to sign up. So I just want to welcome you. Yay, we're all here. We've all made it through these last weeks. Some of you have been in school since early August, our colleagues out to the western part of the state, like Shenandoah and Bedford, and many of these school divisions have been going it early on. They've almost been a pilot of sorts as to and modeling how school nurses have been able to really get on board with COVID and change so many of their policies and practices to create a safe environment for return to school. I recognize that many of you are still all virtual, and that may or may not change over the course of the year. So that is why I'm seeing the reflection of my glasses in my in my laptop. So anyway, if you are that this is why it's been important to ensure that our students
They
have,
knocked 2 of them off, Sean said.
okay, can you go ahead and mute your lines? I'm hearing some talk there. Anyway, at least it's not somebody going through the drive-through like I heard on another previous Zoom. Like, you can laugh if you were at that Zoom meeting. It was pretty funny. I guess you had to be there. So anyway, I'm going to go ahead, and if there's no one else left to introduce themselves, then I am going to go ahead and move on to, going to go ahead and share my screen. Actually, I'm going to introduce our speaker. Joanna, are you on?
Tracy, I'm on, so you were ready to flip the screen?
Yep. Susie, are you going to do Susie's slides? That'd be great. So, this is very timely. Joanna Pitts, who I'm telling you, she's my right arm and my right leg. She's been wonderful. She is, you don't see a lot of her face, but she is just such an integral part of this team. It's wonderful. So I want to go ahead, and I have the distinct pleasure of introducing Susie Trotter to you. Some of you that have been around for a while in school nursing remember Susie Trotter from Chesterfield County Health Department. I worked for a number of years with Susie on the School Nurse Institute Partnership, which is a collaboration of university schools of nursing and the Department of Health and the Department of Education, school health specialists, and other agencies to promote advanced practices and professional nursing, school nursing practice. Susie retired, but she has been brought back. So she's a great face to see here. And she's going to be talking about the tremendous effort that the Virginia Department of Health is making regarding testing. And so as a school nurse, previous school nurse coordinator in Chesterfield, I just want to introduce to you Susie Trotter. Go ahead and take it away, Susie. Great to see you.
Wonderful to see you. Thank you, Tracy. Can you hear me?
Yeah, can hear you.
Very good. Well, first and foremost, thank you very much for inviting me and bringing this content to truly the stellar public health force in the community with school nurse coordinators. One of my most challenging jobs, one of my most fulfilling jobs, and I'm pleased to be here with Tracy and Joanna to help support knowledge sharing where I can. So thank you very much. I did miss Tracy. We had some shenanigans before. We've presented nationally with NASN. So it's great to be back. I'll try to keep it as stellar as that. So thank you. And thank you, Joanna, for sharing the screen for me. I'm gonna put my readers on and get close up. So hang tight. Alrighty, so as stated, I've been brought back. I did receive a phone call from the Deputy Commissioner from Virginia Department of Health, Dr. Param Jabari, who's on the line listening, I believe. We kind of tag team this whole project. I was brought in July to support and have really built, an arm of it per se for testing. So glad to be part of it. I think the next slide will show just a little bit of agenda of what I hope to share with you all today. And first is just a quick review of the Virginia pandemic response. It all started back when March seems forever ago, and then it just seems like yesterday. So I'll touch base on that, a little bit about Virginia's testing strategy related to the pandemic, touch some data of what we look like today. And then as with all testing, it goes hand in hand with isolation and quarantine. So take a moment to bump those two words out again and address those. And then we're going to review a little bit of the testing types. There are numerous out there. And so I just kind of want to dwindle it down to maybe some take-home points so you can understand the complexities and really where we are now in the Commonwealth. And then, as always, resources for the school nurse coordinators. And I'll be glad to stay on for questions or answers. And I am more than happy to come back at a future time as it evolves. This is an evolving pandemic. It is a marathon. It's only as relevant as today is. Things rapidly change. So pleased to give you an update today. Next slide.
Are we muted? Yes.
Other way. Thank you, Joanna. So here we are in a pandemic. Working with several of you before, we did other health emergencies such as H1N1 and many different influenzas. This one itself emerged, as we all know, in Wuhan, China in December of 2019. And it is caused by a virus, SARS-CoV-2. I know there's a lot of terminology thrown around, but SARS-CoV-2 is the severe acute respiratory syndrome, and it's the coronavirus number 2. So I say that because this is a respiratory emergency. There are many symptoms, and we'll touch base on that in a minute. But just to keep that in mind, that this is a respiratory pandemic, and it is COVID-19 is another shortened term, which is coronavirus disease in 2019, because that is when it was discovered. And corona, just really means the crown, and so there's the graphic there of what the virus itself looks like. It's really kind of cute, fluffy little thing with red horns, but we really want it to go away. So that's where it started. It then actually moved quite rapidly into a global spread. Travel related, first reported in the United States on January 21st. Shortly thereafter, the World Health Organization declared it a global pandemic on March 11th. And you'll see on the next slide, the very following day on March 12th, Virginia's Governor Ralph Northam declared a state of emergency. So by doing that, that allows access to different resources for an emergency, certainly funding, manpower, a lot of different regulations. And so by declaring that emergency, we in public health then were able to launch our approach. So the next slide, it was wonderful to hear all the new folks. I know some are just now as a school nurse coordinator and have experience as school nurses, but just as a reminder, the Commonwealth is broken up into 35 health districts. So from a public health perspective, we look at our Commonwealth and our folks as through that lens of public health and population health. And so although the pandemic came on fast and furious, and we were certainly in tune to the needs for the intensity, there were deaths, there was hospitals, we needed ventilators, we were running out of testing. We still also have to keep in mind what it looks like for the entire population, not just those with the disease. So concurrently, while we were looking at how to approach the gravely ill and support our infrastructure, at the same time, we needed to continue to beat the drum and look at the whole population and what are our needs. So one example on the next slide I'll share is we always look at public health as a coordinated response. It's not just the state health department, but it's all those in the communities that share a role. And we've done that exercise before where schools, churches, private partnerships, everybody is part of that health or that public health structure. So this slide here just kind of shows how we're looking at it at our public health coordinated response in the 5 regions. So when you look at the 35 health districts, they're broken up into 5 regions that may or may not be, but mostly typical in that region. As you all know, better than me, what occurs, on Eastern Shore, what occurs, in Rappahannock, what's going on in Bath County. It's all very different. It's independent based on the population of those areas. And so it's very critical to bring the folks together within those regions to address what are the needs. And so this slide is showing our coordinated team for the COVID response. And it includes different partners as far as what kind of support is needed. In the green box are our testing folks. Again, my role with this pandemic response is within the testing unit, but no testing alone can solve a pandemic. And so with that, we have containment, contact tracers, mitigation, communication, and we work as a team at the state level, regional level, and local level to address all needs to work on this pandemic. So just wanted to give you that background that it is a comprehensive approach. And then I'm gonna, bring it down a little bit more to just our testing strategy. But do know we have, many layers going on at the same time so that testing can be effective. So the next slide is actually on our website. And I do know today it was a little difficult to get on at the state level due to some issues with the lines, but this is our Virginia Department of Health testing strategy. And it basically outlines what the priorities are. And really what that means is everyone is actually a priority. But when we look at resources that are scarce or timing of resources, there may be an area of where we really need to focus in resources that can't be found, in another way. And so the project that I work on at the State Health Department is really those testing areas, community, high-risk areas that aren't able to access testing in another way, i.e. private lab, other fundings. And when it first started in March, I don't know if you remember, but we were running far and fast just to get resources, just to get tests across the United States, and really globally. So you start out with, okay, well, who are our priorities? We needed to identify the disease. And then by identifying the disease, then you know where to follow up and what your strategy and your implementation is. So if you look at this box, there's a lot on there. You're welcome to go back to the website to look later. But on the left-hand side is the private commercial labs. And so that's kind of outside of my zone, although I'm aware that it is there and it's an important and critical piece. My side, working within the Virginia Department of Health, is really that public health lab testing. And so we provide resources for communities that are in need to get testing done. It is a cooperative event. So you need the local planners, the emergency planners, you need local health departments, you need the epidemiologists, you need folks on the ground there. But when it comes to a need for the actual specimen kits, if you have need for someone to actually do the specimen collecting and then to secure the lab to run the test and the couriers to bring them, that's where public health came in and said, all right, let's leverage it. Through that declaration of an emergency, funds were released, resources were released, and so we are addressing testing strategy through that modality. So I can say at the beginning, this was a really critical table because there were some decisions that needed to be made. I can say luckily now we're a little more flush in resources, and so it's not as tenuous to look at high priority versus priority. And again, those are always painful words to say in public health or in any health because every life is a priority. So luckily we are at a better state of resources and we're able to provide testing really more broadly than we were at the beginning. So in the next couple slides, I'm going to show you just a little bit about where we are with some data snippets. And this comes from our internal SITREP, our situational report. We have weekly goals at the state level as well as the local level. And so this snapshot here, very, very happy to say, even though it did increase a little bit, the positivity rate across the Commonwealth is at 4.8%. And that is just, although we want to celebrate, we still want it at 0. And so it's actually at a good level. It increased a little bit from 4.5%, but we want to keep it below 5, and we really want it eradicated. Other snippets there that pop out, you know, our hospital capacity is at 79%. So, you know, we want to keep it there or less. Like I say at the beginning, you know, of the pandemic, we all heard about, you know, hospital beds, ventilators, and the high percent positivity. So we are making gains. We're making inroads, which is very exciting to know. Over 2 million PCR tests have been completed in the Commonwealth. That's quite a few tests. You can imagine then the impact on the infrastructure in the lab. So several things have been in the works. One are contracts that we've gained at the health department so that the local health districts can utilize them, as well as our resources within, and those are turnkey providers. Different companies had availability to go provide the manpower as well as the lab capacity. And so we've added those contracts in. 8 labs, 1 lab with other state public health labs, and that's increasing capacity. So we're really seeing some inroads with testing, and so availability is much broader than what it was when this all first started. We do community testing events. You can see on the right-hand side, the CTE, and that's where the local health districts who really know their area and really know where they need to do outreach are working with their local government and emergency response folks and creating these community testing events because they have individual testing goals as well. And so we're here to provide that support. You know, as long as we're helping to break down the barrier for testing, as long as they've got the ability to set it up, we have the ability to link them to a lab, which is really, really pleasing to share. In addition, you'll see the Virginia National Guard there. They were actually brought back on. They had completed their original mission and the president extended it. So we were able to, and are utilizing them to complete the PPS, the Point Prevalence Survey, which is a baseline testing of an entire facility. And the original request was for all skilled nursing facilities. If you remember, that was really the bulk of positivity and actually death. And so one of the first initial things was to get in there and get the baseline and see where we are, and then rapidly be able to respond, contain, control, and provide resources. So they did complete this skilled nursing facilities. They're now back helping us with a few of the assisted living facilities that are left. But in addition, since they're here, we're lucky, we're using them also as a strike team. And so, for example, jails, local jails, Department of Corrections, we have behavioral health, other congregate facilities that need support with testing. We're able to mobilize them to the area and do rapid testing. So it's really been a great resource. They are here with us through December, and then, you know, we'll see how it goes. Just with everything, you know, it's an evolving situation, but so like I say, we have more lab capacity, we have more contracts, we have more resources, and you can see that bottom corner where the average turnaround time for laboratory is down to 1.45 days. So much better data than what we had in March, April, May, when schools closed in the spring. So the next slide, it's very busy. I don't want you to get overwhelmed, but I like if you just look globally in the center. There's a 1, 2, 3, and those were the governor's phases of reopening. So you can see the beginning of March, you know, where we had 0 daily new cases, and then we rode the roller coaster up. improved dramatically throughout the summer, June and July. And then as you ease back into your phases, there's different opportunities to mix and transmit. And so it's a fine line between opening up the economy, opening up business, and having the ability to continue to sustain ourselves as a Commonwealth versus completely shutting down and not being able to rebound. So as we opened up the phases, we did have a few more cases, and we're kind of at a steady tick of cases through July, August, September, October. There are pockets of outbreaks which indicate those higher numbers, but the slide or the graph to the right kind of speaks to our testing and what that has done. So if you look at I think it's orange, it might be red, but back in March, we're looking at the PCR positivity rate, and it was a huge spike in March to April. And certainly you can imagine we had short resources, very little resources. We had extremely ill people. And so testing ill people and our numbers shot up. I mean, that completely makes sense. And at that point, though, what we really needed to know is if it would a dream come true, we needed to test every single person on the same day, and then we would know our prevalence. But we needed to ramp up our testing in order to know, instead of testing every sick person, we needed to also test the contacts and those people in the community, so that we can see where the prevalence is and really where the disease pockets are. So that's that blue line right below it. We did not have very many tests at the beginning. Now you can see it towards the end, we have a lot of tests. We're over the 20%. Our goal is 15,000 tests a day, and we're superseding that. And through that, then we're finding that our percent positivity, because you have a better representation, you have a better mix of tests, is where it has dropped. So it's a better picture than what we had at the beginning. It's still more to do, but I thought might enjoy, seeing where we've come from the last time when schools were closed down. So the next slide is just what it looked like in September. Again, local health districts have a testing goal. The state itself has a testing goal. And if we looked at that 15,000 tests a day in the variety of communities and the variety of areas and risk populations, our September projection was 450,000 tests. And through the variety of testing, not all state health department, but we were able to meet that at 470,000. And when I say we, that's not me. That's the Commonwealth. That is soldiers in the field. That is community partners. Those are the tireless front. Besides, the frontline staff in hospitals, it is the community as well that's really adopted this. So we expect that to continue through October and through the end of the year with testing. Again, our resources are up and our ability to do that and support is there. So the next slide just gives you an idea of where all the testing locations are besides the health department. So besides the local health district and community testing events. Sorry, it's tiny. You all have the slides so you can reference back if you want. But every week, we look at the numbers and we update it. It is a data-driven decision as far as testing goes. Where is it happening? Where are the gaps? What do we need to do? Who else do we need to bring out on? Are there partners we're missing? And so if you look at the testing locations, there's federally qualified health centers, free clinics, pharmacies, sundry, urgent cares. So they're also doing testing, and that's independent of the state health department resources. So again, it's kind of a two-pronged, public-private, but provide resources to those in need. And then the private side is also developing and have developed their approach to testing as well. In addition, the pharmacies have really grown. CVS in particular has hundreds in the Commonwealth. Walmart, Rite Aid, independent pharmacies, Walgreens, Kroger is looking at a take-home kit for their employees. So they're very creative. A lot of it goes along with the concurrent ride of technology and science. As science improves and technology improves, they're able to adopt new methods, and we'll talk a little bit that, in a moment. So overall, the slide or the picture on the right, between commercial, hospital, public, and then unlabeled, this is where we get our turnaround time from the labs. So bulk of them, almost half, are commercial. And so there it is established, it is in the community, which is great. Good to see, and don't expect that to change at all. So that's a little bit about the data. The next slide, this one is, I think might resonate with everyone here, is when you look at the transmission of SARS-CoV-2 and what the signs and symptoms are, that's really almost every student every day in any school, that these symptoms across the top, except for maybe the new loss of taste or smell. But I would gather to say there's going to be some of those creative students that are going to have that as their number one symptom. But not to make light of it, it is a complex novel disease. It has fever, fatigue, cough, shortness of breath, headache. It has all of these sundries. But to remember, it is a respiratory disease. So focusing in on that, it is felt to be mainly spread person to person through those respiratory droplets. It does spread, they believe, more easily than influenza, but a lot less than measles. Where influenza spreads kind of one person, 1 to 2, measles was 1 person to 14. Right now, SARS-CoV is looking like that 2 to 3 transmission rate. So again, respiratory, really close contact is how it's mostly spread. So, even though you say you were in an auditorium and the person that was ill was more than 6 feet away, is that really how it's spread? Certainly it's a concern, but we look at spreading mostly through that close contact, and I'll go over that in a minute. So those droplets are produced when we cough, sneeze, talk. Then, of course, mucosal membranes. Wet to wet, so the mouth or nose of uninfected persons, bring that in, and then starts the incubation period. Just this October 5th, the CDC did say that the virus, they're noting the virus can be spread in an airborne route, very small droplets, or particles that can linger. So that could possibly infect people that are greater than 6 feet away. Again, that's just new information that has been shared. More to come from that. I think it just goes back to, as we all know, is public health hygiene, masks, hand washing, wash your hands before you touch your face, and all of the like. And then we don't really have to worry about it. However, there is close contact, and the next slide will bump out a little bit about what that means. So if, in a scenario in a school and you have a staff meeting and you're all there and somebody turns positive, and so what does it mean? I've been exposed to this person, but I'm not symptomatic, but I do meet the criteria for a close contact. I'm within 6 feet, I've been there 15 minutes or more, or I've provided care to someone with COVID-19, or I have direct physical contact, hugging, kissing with this person of COVID-19, maybe not at a staff meeting, but in another arena. Shared the same utensils, directly coughed or sneezed. So this is that direct close contact. What does it mean if I'm not symptomatic? At that point, certainly testing should occur, most specifically a PCR, and I'll go over the difference in a minute, but then I should be quarantined. So basically there is an exposure, it's a close contact, I don't know what I'm incubating at this point in time, and I need to quarantine for 14 days from that exposure. If a person is not symptomatic and doesn't meet that definition of close contact, then they probably don't need to be quarantined. However, they really need to be aware of the symptoms and practice that good general public health measures. But if they become symptomatic, then of course they need tested. So when we talk about quarantine and isolation, so back to me, who was at that meeting, and I got exposed, but I'm not sick, then I do need to quarantine away from others for 14 days and see what my body is doing if I'm incubating. If I happen to be positive, if I'm symptomatic, if I test positive, then we already know my incubation. I've already been cooking. And so at that point, isolation is the next 10 days from the first time I had the symptoms. So it gets confusing a lot of times with folks, me too, the difference between isolation and quarantine. So we isolate the sick. We know they're sick. We have a positive test and we isolate them. And that is to minimize the exposure to others. We already know they're incubating and they're shedding virus. We quarantine the well and we hope that they stay well. But that is a concern for someone that has been exposed to a close contact, and they really do need to quarantine while they're incubating. And the next slide will show a little bit as to why we quarantine if you've been exposed. So if you look at the left-hand side, there's that little coronavirus with its little prickly horns on the crown, and we've been exposed. So this is the incubation period. We got 2 to 14 days. We got two days to 2 weeks that the virus is spreading in my body. I don't know it. I don't have any symptoms. It's just replicating away. So then you come into the symptoms start, whether it's fever, cough, headache, or any of those symptoms. It's unique and different for each individual. At this point, we know that 2 days prior to me getting symptoms, I am infectious. And so that's the risk area right there. I don't have the clue or the indicator to say, hey, I'm sick, stay away from me. It's really 2 days before that. And so when we do our contact tracing and contact investigation, it's like, who were you with prior? And so this is the reason to quarantine. And I will always say, if we're putting a Q-tip in somebody's nose, that also goes hand in hand with you now need to quarantine yourself until you have the answer, because the test itself is worthless unless we have the behaviors that follow. Not worthless, you know what I mean? It's my passion. If you're not going to follow up from the test, then, why test? But there's the infectious period, 2 days prior. So now you have the isolation, that orange piece on the bottom, 10 days. 10 days have passed since the symptoms started, and your symptoms has improved, and it's 24 hours without fever. Now, when it says improved, and that's the CDC's language as well, it's some linger. The nose, the smelling, the taste, that will linger, but that they have determined that that's not an infectious state if you're past those respiratory, the cough, the fever, that real infectious state. So therein lies that whole picture of quarantine and isolation. The other reason that this is important, not only for behavior to contain and control the pandemic and the virus, is really what testing do we do when? And I think that's important, especially as school nurse coordinators, to understand in the dynamic environments that you exist, both with students as well as staff, community members. The quick answer to everything pandemic is test. We have to test to know. But the real answer is, when do you test and what test do you use and what does the test mean? So this next slide, I'll just take a brief moment to share with you. There are different types of coronavirus testing. And this came from the FDA, and I know as well the CDC has some updates. But if you look across the top, we have the molecular test, an antigen test, and an antibody test. So the molecular test, that first column, that is our gold standard. And that is that NP swab. As you look down, it can be taken by nasal. How long it takes to get the results. This is where they take it into the level 3 labs and they actually go into the genetics. They separate it and, apply treatment to it and then actually reveal the genetic of the virus. And so that is diagnostic. If you get a positive PCR test, a positive molecular test, that means we found that virus on that nasal swab that came from you. And so it's highly accurate. It does not need to be repeated. And basically then you can take actions from that. And that would be the 10-day isolation, no symptoms, you can be released after that. It diagnoses an active infection. Now the antigen tests, and I'm sure you've heard a little bit about those coming on board, they're just a newer technology for COVID-19. We've had antigen testing before. Everybody's familiar with the strep throat test. That's quick in the office, 15 minutes, and we say, yeah, there's indications, and so we better treat with this. As far as coronavirus goes, it is a newer technology. It is rolling out kind of as we speak, but it's not the true molecular. It does not pull out the entire virus where the PCR does. What the antigen test does is it will show a particle of that virus. It's the protein that it picks up. So it's still a nasal swab. It's a little more friendlier than the NP swab, but technique is still very critical. It's not just a one swipe and go. There is a process to be sure you get a good sample. They say it takes 1 hour or less. Most of them are saying 15 minutes, and that is, point of care on site, do the test and get the result. Positive results are usually highly accurate, but negatives need to be followed up with the molecular test, and I'll go over that in a minute. So it can diagnose active corona infection if you remember when you're going to do the test. So if, for example, we're at that staff meeting, found out somebody's infectious, I was there, I need to get tested. If I do the antigen test, I have not had viral replication yet enough to get a positive. So even though I might be brewing, I don't have enough of those particles in my nasal passageway to say it's positive. So you really need to wait out those 2, 3, 5 days in order for you to get that viral replication. So that's the testing part. There'll be another slide coming up, is when we say that there's been exposure, we do need to be mindful of how long it takes the body to react in order for a test to pick it up. And then the last one is the antibody tests, and there is, serology tests that are done. And what that will show is if in your blood, blood test, have you built up the antibodies within your system that will show that you have had an exposure and your body has reacted to it and already has built the antibodies. So as far as usually using that testing modality for a diagnostic, it's really late in the game. Because in order for you to build up your antibodies, you're 2 weeks down the road. And we really need to contain and control the virus and the pandemic at the forefront. And so that's kind of the more focus for getting the antigen testing up to speed and maximizing our PCR molecular testing far and wide in the community. So the next slide shows, again, a little bit what I said about the advantages and challenges. Further with PCR testing, it is accurate, highly accurate. It is our gold standard. It will diagnose. It is the reference test at this time, but it is expensive and it does take longer to get results. So there are some indications where no matter what, we need to get a PCR test on someone, where others can do the antigen test because it is quickly, it can be done quickly. I think it depends on the modality, but it's a $5, a card. There's faster turnaround time. But the key to the antigen test challenges is it's meant to be used in symptomatic people who are thought to have COVID-19. And so screening the asymptomatic folks, it's like I said, it's not going to pick up the viral load in the nose. It was designed to be for symptomatic people. And so they were really in the early stages of where to deploy these types of tests so that we get an accurate result. The last thing you want to do is use the wrong testing modality at the wrong time. So there is the CAT, the Commonwealth Antigen Testing Team, is currently meeting with various stakeholders. Of course, VDOE is one of them. as far as what to do with these, how to use them, what's the best approach. And so we can really be assistive and help out the community and the public. So the next slide, I don't know if you'll remember, but, oh, yeah, there you go. So back in late August, Department of Health and Human Services and the Department of Defense awarded a contract to Abbott to deliver quite a few, 150 million rapid Abbott Binox Now COVID-19 cards, point of care, and I'll go over that in a minute. Diagnostic tests, and that was to expand, that evidence-based testing. And discussion that potentially deployed to schools and assist. And again, that word potential is there because, as I just discussed, it has to be the best application for that test. Just because it's easy doesn't mean it's really going to give you the results that you're actually looking for. If you hit it one more time, Joanna, then an overlay will be where Virginia actually also committed to purchase COVID-19 rapid antigen tests as part of the state compact. So in addition to the HHS Binax Now cards that we're getting, there's also an additional 200,000 rapid tests that are coming out. And again, both of these are going to be deployed based on the CAT, the Commonwealth Antigen Testing Team's prioritization, working with the partners to see really how to operationalize it and get it to the people that need it the most. That's going to be the right approach for this testing modality. So you might be interested in the next slide. It's actually pictures. I'm a visual learner. And a little bit about a point of care. And I think it's important to understand, as you know, in the school setting, you are asked to do a lot, and it isn't an education. It's a building. It's a system of education. It's not a clinic that is a medically driven with a CLIA lab and a physician, et cetera. It's you on the island. So in order to do any of these rapid antigen testing, even though they're simple, even though they would be easy to do, it still requires a point of care, meaning it needs to be analyzed by the ordering provider. It needs to be written by the ordering provider. The sample to collect is easy. The results are rapid, but then there also must be follow-up. And so that's where, I talked to Tracy a little bit earlier, operationalizing that is early in such that there's no even A, B, or C right now. It's just, we were just heard that they're here. What can we do with them, and how does that look best in the school setting? But you can see the system on the left, the Benetton-Dixon Veritor system. It's a little device. So when you use the nasal swab, you put it on, it kind of reminds me of, the old glucometers. You put it on the stick, you insert the machine, and then 15 minutes, use the reagent, and in 15 minutes you get the answer. The one on the right is what I was talking about earlier about the Abbott Binax Now COVID-19 AG card. And so this does not require a machine. It does not require that analyzer. This one is more akin to like the urine pregnancy test. Still requires the nasal swab, still needs to be done effectively and appropriately. You do need to twirl it so many times in both nares. And even when you put the, the reagent on it, there's a dropper, you need to then insert it into the card, and you still need to twirl it around. And as simple as that sounds, we certainly have had, complexities in the community of folks and how they've approached testing. So technique is critical. And then again, in 15 minutes, the provider would open the card, and there will be those plus minuses that you're akin to with like a pregnancy test. So the concern going forward, however it is operationalized, it is key to remember, and you guys will probably be the ones that have a lot of questions coming to you, is can I have one of those cards? Can I take one of those cards home? If I only had one of those cards. But now a card is worthless if you're not shedding the virus. If you were just came out of Home Depot and somebody was sneezing, it's not really the method or the testing modality that needs to happen. isolation, quarantine, and then appropriate testing is where you need to go. So I look forward to, working in the future with VDOE as I can. There is an antigen testing team that's working on that. Tracy's in good hands, and Joanna. So I'll be glad to come back and work with you all if needed on once it's deployed. So just as you know now, it's not here. It's in a warehouse, and the next step is how to plan for that. So the takeaway on the next slide, is the limits of rapid antigen testing. These have been given a clearance, an emergency use authorization from the FDA. And emergency use is for people with symptoms consistent with COVID-19 early in the course of disease. And that's where that viral replication is happening. So it's really not clear what the role of this antigen test is for screening asymptomatic people. So that's where the decisions are going to have to really be made on where to deploy these cards. The next slide looks extremely busy, but it kind of feeds back to what we talked a little bit earlier about the timing. And so I'm going to leave it with you. You can reflect back to it, but this was a nice graph out of the Journal of American JAMA, Medical Association, JAMA. But if you see on the left, that's the before symptoms start, that gray, there's that little virus. And you see some rapid spikes there all in that week 1. And if you look below on the colors, the blue is the PCR. I can't really see the red is that, if you see that red mountain, so red goes up and red goes down, that's your viral replication, and that's where antigen would fit in. But if you look down the blue slope, that's PCR testing. We can continue to get a positive test 7, 8, 10 days down, even though you feel a whole heck of a lot better. And so that's been confusing to folks, like, well, they're better, but they're still testing positive. Did they get infected again? When in all actuality, that's the PCR is that gold standard, still picking up the virus within the body, but it doesn't mean that they're in that infectious state. So there's complexity to testing, and so I support you in being knowledgeable and working with your local providers and your health leaders and your parents, and educating that we really want to be able to provide the right test at the right time so that you get the right diagnosis and know what actions to take. And so really leading on the local healthcare providers and working with the families is key across this 2-week time frame. And so on top of all that, then what can we do to help you with testing? As I mentioned, going forward, there will be things changing tomorrow. It is the most flexible job ever. When you hired, I don't know if you were asked, but how comfortable are you with uncertainty? That is the world we live in. And so I join you. We are in an uncertain world, but one thing is for sure is that we are here for you. We appreciate you and all that you do. Most satisfying and most scary job was working with students in school communities and parents that were just really, you are it. You're the only thing they have. So the next slide, we'll just start. I have a couple pictures in here for you of just kind of what resources are available. Again, I'm a visual person, so this is a picture, a snapshot of the VDH website if you haven't been on it yet. And we have a COVID-19 resource page, and each of these little pictures you can click on and get to a plethora of information. So of course there's COVID-19 testing and the priorities, COVID check, like what are symptoms, and you can walk through it and say, I've got this, this, and this, and it'll kind of give you an idea of what to do. So you can share that with your folks, and then what to do if you're sick. And this is just a snippet. There's more resources there for you. But the next slide, I clicked on that COVID-19 testing site, and I think this will be helpful for you going forward. This is a dedicated page to where we are aware of testing currently, and you can pop in your zip code down to your location, and you also have the ability to check different areas if you want, like, is it a drive-through testing? Is this a free testing? And the far right on the bottom is the pediatric screening testing, and that has been added in more recently. So you're able to help your family, you're able to help your community by looking at where
Creek Central.
available. And then the next slide, I won't speak at length because now I'm crossing lanes, but we have a great partnership, as I shared, with VDOE. Wherever the candidate may get information, we replicate K through 12 education. We work in parallel and in support of each other. So there is a page there as well. The next slide, I think you are going to address a little bit later in your meeting today, but these resources as well are on VDH. And the next slide is kind of there's a lot of infographics, there's a lot of handouts, there's materials you can use. And this is, in a non-healthcare setting. So in a school, when do you end isolation? And these can be utilized, in your newsletter. They could be on your website, a link. They could be sent in, any manner of communication, share it with your school board. These resources are there for you to help support the community. And the next to last slide, Mask Up Virginia. Again, testing is only one tool we have. Testing is going to let us know where it's happening, but really what's critical is to isolate, to safer at home and safer in school means wearing the masks, keeping the distance. If you're sick, stay home. Easier said than done, I understand. But, wear your mask. This is one infographic that we have in partnership with VDEM. There are others that you could utilize. And then the next slide also shows our different languages, and it's different materials related to when to end isolation, what to do, when you're home, what does a positive test mean. So we have it in Arabic, Chinese, Korean, Spanish, a variety. They're still being built in. And then infographics that may relate more, like say you're in a high school and you've got a high school student wearing a mask, that speaks more than it does. Unfortunately, any of us, we're just too old and irrelevant maybe, but you all are leaders. See one, do one. You all are wearing your masks, but I know resources help back you up too. And then the last slide, I would like to just share a moment about COVID-Wise. And that is an app that has been built. Virginia is the first state to have it. It is a Bluetooth technology. So it's not a GPS tracker. It does no idea exactly where you are. It's just a Bluetooth kind of a radar, I guess if you say. It puts these markers on your phone. What happens is it will generate an anonymous token to you if you've been in that same area of another Bluetooth low energy zone of a person that was positive. So it gives you, i.e. you, your staff, your students, have you been in an environment where somebody turned positive? It doesn't tell you who's positive and it doesn't tell you where you were, but it will tell you that there is a, possibility that you have been exposed. So if there's a phone in your environment that has downloaded COVID-Wise and has it activated, then you have that better chance of exchanging those privacy tokens in that passive process. In order to say, keep the anonymity, they keep changing the tokens every 10 to 20 minutes. So they don't know who you are. Again, this is technology beyond me, but I see you, Tracy. I almost called you Janet. God love Janet, miss her. Yeah, so Tracy has it, I have it. In every week, they will give you an update. And I love it when it says you have not been by anyone else that has tested positive. But it also gives you the opportunity, if you turn positive, do you want to send out that signal to say, hey, let those in the Bluetooth connection world know that they were potentially exposed. So it really helps for the Commonwealth as a whole. The more that are on it, the more effective it will be. I know at last count, we were over 500,000, if not more. But same thing as we started, we had low testing ability. Now we have more, we understand the prevalence. Same with COVID-Wise. The more we have on it, the more we can understand and get rapid response to really contain and control who has the infection. And that's the key. We can test and test and test, but unless we get the behavior to follow, we're still all kind of uphill on that. So I would encourage you, if you can, share or learn more about the COVIDwise app. That's a great feature, especially in a school setting. And then, finally, just a huge thank you. I greatly appreciate, I think the best part of my job prior was the relationship and the partnership with the Virginia Department of Education, with the Virginia Department of Health, with the school nurse coordinators as leaders throughout the Commonwealth. I appreciate your time. I wish you all the best going forth with this pandemic. And I'll be glad to answer any questions. I toss it back to you, Tracy, if you want to do it now. I know you have an aggressive agenda.
Sure.
Or I can follow on the chat and answer as you need.
Sure. I just wanted to confirm, can we share the slides, Susie?
Yes. Yeah.
Okay. All right. So that's the conversation. And I do want to, we're going to share more about this with you, but the improvements, the enhancements to the algorithms and the new products that have been posted as of Friday are fabulous. And we did, Joanne and I did advocate on the part of school nurses to make sure that this was a little more easily understood. And with you in mind, and the fact that not every school has a nurse, a registered nurse in the clinic. And so we wanted it to be understood. So you really have to look at it, but there's also some, we'll talk about that more later, about accompanying information later on in the meeting. So, all right. So, and Suzanne says the new algorithms are easier to understand. I know that in the chat, let me just go back to the chat box, and there were a few questions. I know Patricia Knox from Bedford County asked this question. Let me scroll back to it. She said, this has to do with the local physicians. We have been using 48 to 72 hours as our most contagious time for exposure, close contact, and to determine possible need for quarantine. We are now getting notes from doctors that are using the full 14 days as a reason to quarantine. This creates a lot of confusion among parents, staff, and contact tracers. How do we want these notes handled, and have we seen this? So, there is no, I will just say that there is no, nothing mandated that, or no rules that say that students returning to the school setting need to have a release note from a physician. And so because of this, it makes a lot of schools nervous. It makes a lot of school nurses nervous as to how to track these kids in a responsible way, and staff members, and keep their schools safe. Susie, do you know if there's going to be anything moving forward regarding notes to return to school, or Dr. Jabari, do you know anything about that? I'll just ask our guests.
There, now I'm on. Yeah, I concur with you, Tracy. I don't know that that there's anything coming forward. What I will do is bring this back to our clinical advisor, Dr. Brooke Rossheim. He is in communication with the different varieties of medicine. So family practice, American Academy of Pediatrics is meeting. So I'll bring that to him to address, but I don't know about a 14-day without returning to school. That's a good question.
So, and I will just say this too, that whenever a student is out for isolation or quarantine, schools need to be responsive, and depending on the student's state of wellness, be able to provide an alternative type of work for them. That is not our job as school nurses, but we do need to sometimes act to facilitate this information, to our administrators and staff. And so, yeah, the student may be out for a time period. It doesn't mean that they need to be, it doesn't mean that they are necessarily absent from school if they're given like a work assignment, if they're working virtually. So there should be some alternative forms of makeup work or a way for that student to maintain current assignments and things like that. So, and Alex, and this is more to do with the algorithms and about, and I don't know if you can answer this, Susie, but she said the algorithms are great, but have received a few questions regarding 10-day isolation for one symptom. Algorithms do not identify specific symptoms or number of symptoms, thoughts, clinical criteria. And I'll just say that I would say this is, Alex, and for those of you, I think many people are just being very conservative as to how they respond to this, especially in your area, Alex, in Spotsylvania, where there's a higher population density and we have to be concerned. They're just being very cautious. That a physician from another area may not be doing that, but that is just something that's going to depend a lot on the locality. Again, a 10-day isolation from school does not mean that that student has to go without education. They're missing 10 days of school. So one of the challenges that we're facing is for those where kids are not able to attend in person, that they can pick that up online in some way, shape, or form, so that they don't lag behind. So,
Tracy, this is Patricia. Can I go back to my initial question, if you don't mind? What that amounted to was we received a note yesterday from a parent, and the child, it was a divorce situation, and the child was with the father on 10/4, and then just for that one day. And then on 10/10, the child or the dad was tested and was positive on 10/11. The child that is in our school system is not showing any signs of anything. So the nurse said there's no reason to quarantine him because he's not showing any signs of anything, and therefore his exposure was on 10/4. And so we were seeing that his time level was past what we normally would look at. And so the mother took the child to the doctor, and he said, well, actually you could go back 14 days, and today is the 13th, and yesterday, you see what I mean? And so he's saying we need to put the kid out because it would have fallen within this 14 days. So when I looked at Susie's chart, which I thought was excellent, it showed that the incubation is 14 days when it grows inside of a person, but the infectious period is really those 2 days that we have been actually using, but we've extended it even further. So we thought we were in the right, but the mother's going with what the doctor wants. And so that's why I probed you that question.
Right. And, and Susie, feel free to comment, but we will be having Diane Willard from VDH to talk about this on Thursday. We'll give a more in-depth discussion on the new algorithms that are posted in the booklet from VDH that really can address this. So Patricia, we may not have that answer for you today, but it is coming, because I know there's nuances in every situation, and they just require some conversation, discussion, so we're all on the same page. So I want to thank you for bringing that up. Please hold that for Thursday, if you don't mind, and we'll get you the answer for that. Okay?
Thank you.
Because that is not going to be an isolated situation. We're going to be seeing that, and we kind of have to ride the road, and depending on where your location is, and many different facets to this. So are there any other questions for Susie? Okay, Glory Gill. You remember Glory Gill? She is asking, do you know why VDH in our area, so that's Hampton, went from data from VDH related to incidence rate and positivity rate to suggesting that we use CDC as information, which isn't always the same in data and numbers. Can you explain the difference percentage of case incident rate and positivity rate? And she goes on to say, I understand positivity rate and how that is determined, but not incidence rate. What does that show?
And this is Glory. The reason I ask these things is because part of the requirement for us with our board is that we talk about the incident rate and the positivity rate. And we've been using VDH, Kevin Pierce, who's the emergency coordinator for our area. And he says we now, because VDH, we've been using their numbers, and then all of a sudden now we're being told to switch to CDCs, and CDCs is a little bit harder to find for specific these rates. And so I was just wondering, is there a move to for us to go to CDC, or where that may have come from? And then an understanding of what incident rate means. You may not be able to answer it. Maybe I should go, I mean, time-wise, maybe not be able to answer it, but I just was trying to understand so I can sound smart enough to discuss it with the board.
You and me both. No, I appreciate the question. And so I know briefly a little bit about that. And what I know is what Dr. Forlano shared in our, operations meeting is that the CDC has gone to 14 days case counts in their numbers for K through 12. And so that puts us in that intermix of, okay, well, that's not how we've been reporting out. And then additionally, the skilled nursing facilities, that the CMS data went to 14 days in case counts. And so VDH is assimilating so that we can get to that 14-day and kind of get a match. So we're working on that. Why it happened, it was CDC driven. And so those are our numbers. So the percent positivity is driven by, many factors. Yeah. Every Friday I do an update with the local health districts, and there's some questions about percent positivity based on how many tests were done in what area and all the lab turnaround times, et cetera, and so it's still a valid number, especially when we've been trending by it. If you just pick a number out of the sky, you kind of wonder about it, but this has been our standard and we've been able to make actions on it. I think there's discussion going forward, and thanks, Gloria. I'm sure you're in on those conversations. Is what is the case rate per 100,000? And by doing it by that 100,000, you kind of neutralize. What does 3 mean in Bath County, and what does 3 mean in Enrico? You kind of have to look at the population data. So we're moving towards that. So we're kind of in that flux of mixed of data, but that goes to being the steward and looking at all different data and say, what does that mean for our community and what actions can we take? So the why is because CDC, and what it will look like going forward, stay tuned. Good question.
This is Parham. Susie, I think you nailed it. Just for a little bit more clarity, as I thought about this, and we're getting the same questions about metrics in some of our other meetings. So it's exactly as you noted. With the incident rate being the number of cases per 10,000 per 100,000, so it levels the playing field. And the positivity rate, there's a true incidence rate out there, right? If you have an X number of people in your community that have an illness, by you testing, it shouldn't increase the true number of how many people are sick.
Right.
By you testing, what you get differently is percent positivity, because if you test in a community event where no one's really sick versus you go somewhere where there's a lot of vulnerable populations, frontline workers, you can get 2 different percent positivities in the same community, right? But the true incidence is the same. So what we're seeing is that as more tests are becoming available, as antigen tests are becoming available, we're beginning to drive that positivity rate down. And it may not be as helpful because there are places like large universities in our counties that are doing testing of their athletic programs, of their college students once or twice a week, and all of this data coming in, testing these, what could be considered low risk, and therefore the denominator becomes big and your percent positivity becomes small. We're like, oh, there's really not a problem. When in fact, the reason the percent positivity is coming down is just because they're testing a lot, not that we've really impacted the number of people who are sick. Does that make sense as I was talking out loud? I'm not sure if that all flowed, but the idea is that you can impact the percent positivity with the amount of testing you do, but it doesn't change the actual number of people who are sick in the community, which is important, and that's the incidence rate.
So pay more attention to the incidence rate is what you're saying? Not more important, but pay more attention to that one.
It is. I think that's going to become more of a factor. And to Susie's point, the percent positivity, and if it starts going above, we've been tracking 10%, 5%, if that starts going up, it means two things. One, you have more people who are sick in the community, like how we were looking at in the beginning, so percent's going up, or you're so lacking resources that the only testing you're doing is for symptomatic people, so percent positivity goes up. So there's still value for Susie and I, for example, from a programmatic side to track this. And as she said, it's for the measure we've been following throughout the last several months. But to make this more consistent and to make this less about testing resources in the community and what really the impact of diseases incidence rate is going to be the better measure. And so we're looking at that. Is it 20 per 100,000, 50 per 100,000? CDC's come up with some cutoffs. And I think that's one reason we're moving that way.
Okay. Any other questions? Thank you, Dr. Jabari. Okay, we're gonna save the algorithm questions for Thursday, and we'll be able to get specific information regarding that to provide to you all. So I want to go ahead and thank Susie Trotter, my friend, and great school nurse. So are there any other questions?
Tracy, it's
Yes,
Joanna.
Joanna.
I have one school nurse sent me an email earlier this morning. I was going to run it by Susie, and the other folks may be interested too. Is there any type of COVID app other than COVID-wise that you guys would think would work well in the school system? They were looking at more lines of tracking students and things like that. And I know there's some apps out there, but I don't know if there's any in particular that we think would be good to use or none would be good to use.
Big question. Big, broad question.
It is a big, broad question.
It is.
So go ahead. I was going to say there are a number of universities that have created apps specifically for their schools. George Mason's one of them, University of South Florida, a number of them across the United States. One of the issues is FERPA with these apps. It has been a concern that these are FERPA compliant platforms. And so, I have talked to some colleagues across the nation, and they tend to be in university settings where they have been built by private contractors and are closed to those university settings. So, but I don't know if there's any other ones for tracking purposes for schools to use. K-12 schools.
Yeah, I'm not familiar as far as tracking students. I think the only thing, is the symptom. You can go online and look at symptoms and what it is, but as far as managing at a school level and tracking, I'm not familiar of an app at this point.
Thank you so much.
No, thank you. I appreciate your time today and the questions, and that's what we're here for. So if you have more, shoot them my way.
Okay.
Yeah, more to come on that algorithm.
Hey, thank you. Yeah, sorry to put you in that spot.
No, not at all.
Yeah. All right. Thank you all very much. We appreciate it. We're gonna go ahead and Joanna, you've got the screen up, right? Can you make it bigger?
Thank you all as well. I'll just sign off as well. We were just so blessed to have Susie with us. I had a great working relationship with her in Chesterfield, and she's been phenomenal. I think nurses think operationally, and when you work in a school setting, you really take care of the whole population. So the application of knowledge and effort really translates well. I just want to put in one quick plug. Someone asked about apps. So I put in what's called the COVID symptom checker. Mm-hmm. We partner with VDOE Health, and you all may have heard about this in one of the early governor's press conferences. If you go to Virginia VDH website and put in COVID check, you're going to get one tab for a symptom checker, one tab for where do I get a test, another one for just FAQs. I put in directly the the company that we partner with. And what it is, if you click on that link, if someone is symptomatic, it asks basic questions and it tries to verify whether those are symptoms consistent with COVID. It'll ask your sex, your age, no other identifying information, nothing. And it basically takes you through this triage algorithm, and it'll say, well, don't worry, or you should go get tested, or you need to see a primary care provider today. And for those who have insurance for adults, if you put in your insurance information, it'll take you to the telehealth platform of those places, or it'll say, you know what, you really need to call 911. So this is an app that's paid for through the Commonwealth. For those of you who may want to go ahead and explore it. Wouldn't substitute for your clinical assessments of students and individuals in the school setting, but thought I'd just share that link. And
thank you.
Thank you all again for having us here today.
Thank you.
Bye, guys. Thanks so much.
Absolutely. Thank you. Thank you. Okay. All right. Now that you're all blown away with information, school nurses do have fun. We do work hard, but we do have fun as well. So, Joanna, can you, am I where I need to be on this? Yeah, okay. Okay. So, I just want to move along and talk about DOE updates. We've got a lot of information. Joanna is just a tremendous amount of information coming from VDH. And what I want to share with this, just want to start off saying that since COVID is a public health emergency, we have plenty of things at DOE. And we share with VDH, but VDH K-12 website is the place to go for information on your algorithms and all that. And if you don't have these things bookmarked, you really need to, in order to be an effective school nurse, you need to share it with the school nurses within your school division so that you can have effective school health programs. So these are just things that you need to know. I want to just talk to you briefly. I've been getting all kinds of questions about hearing and vision. I want to restate that hearing and vision for this year can be done at any point over the course of the academic 2021 school year. It just has to be scheduled on a calendar. Like if you've got your big calendar in front of you, you have to put, oh, I'm going to do this for this grade level on this date and this date. That schedule can be changed, but you have to have it basically posted on your school calendar when you're going to do that. I get a lot of questions. Vision, how can we do vision and hearing when we're in school virtually? For kindergarten students, you can get that information from your K-12, your kindergarten physicals, along with fine and gross motor skills. You can knock that out. That's the easiest one. I think one of the best strategies that I've heard of is, it's interesting, kids coming in for picture day. I don't know why my computer is can I do that later, Mom? Hold on. Hold on just a minute. Let me check my computer here. Sorry about that. I don't know why my computer is running low on battery. But, hear me okay?
Students, please report to the
Okay, can you all mute your lines? So anyway, so hearing and vision can be done at any point of the year. Height and weight, it does not have to be done, okay? If you've got it on a kindergarten physical, you are done. You don't have to do it. Is it a great practice? Of course it is. It's especially great when we notice that there's kids that are obese or kids that are, maybe have a eating disorder. And that's something that you can do. That is a local school decision process. I want to go to fine and gross motor skills. And Joanna, I'm just looking at this. I thought we put up the information about fine and gross motor skills in an earlier, you do that?
We put it on the Padlet, and then we added it to the Thursday.
All right.
The code and all is for Thursday.
Right,
On the
okay.
Thursday
So
meeting. But it's on
fine and gross
Padlet.
motor skills, a lot of questions about that. They can be done. If you need to do them, there's nothing in the code that says anything about a specific time frame like it is for hearing and vision, usually in a regular year. So again, we're referring you to the Padlets. They are updated. Joanna, she loves Padlet, and she's been putting a lot of stuff on Padlet. And so the COVID resources for Virginia school nurses and the back to school is where you will find information on all things screening. So also, those of you that are new school nurse coordinators, there's a school nurse health services website. This is the link to it. There's all kinds of stuff on training, et cetera, that's on there for you to check out. You don't need to guess anything. And I see that Leah mentioned that on her fiscal forms, many say unable to do. We see that. We've seen that here. I'm kind of jumping around here as I'm looking at what is in the chat box. But getting back to the school sites, there's plenty of information on the VDOE website, along with the Virginia Department of Health website, as well as immunizations. We're getting clobbered with information about immunizations. It is all there on the VDH School Health Requirements website. Please bookmark it. Please save yourself an email, arm yourself with this knowledge. It's just really important to have. Okay, we have just been working all summer, especially in August and September, to revise some major documents: anaphylaxis, asthma management in the school setting, eating disorders, diabetes medical management plan, and the medication administration. A few of those documents have to be board reviewed, which I did not know, because they are actually recommended and approved by the Board of Education. So any revisions need to go before the board. I'm not thrilled about that, but that's what we have to do. So that will delay them being published to the website. But there still are good resources there, and you will start to see on the DOE School Health Services website that these have been replaced with the year that they have been reviewed, renewed, and edited. Please encourage your school nurses to use an information ladder system. I really like that. It's a Joanna term for questions or concerns that come up from your school nurses. They go through your school nurse coordinators because when we get a lot of emails, and we want to be available to our school nurses in the trenches wherever they are, but sometimes it bypasses you. And so you don't maybe know if there's a concern or an issue. So we're encouraging you to tell your nurses to communicate with you if there's an issue that needs to be addressed, and then you communicate it with us. That would really be helpful and cut down on a lot of emailing and back and forth. Want to especially for those of you that are new, and a good review of those of you that have been on a board a while, there's a difference between what a state law indicates and what your locality chooses to do regarding policy. Example, medications. I got an email yesterday about supplements. Can we please give the DOE policy on supplements? Well, there is no DOE policy on supplements. It's a local decision. Do I think it's a wise decision? No, because supplements are not FDA approved, and it states very clearly in the medication manual that only FDA approved medications be given, and especially in incidences where the children they need to receive that medication during the school day. Because, many people, many parents will want to, you know, us to give everything. We can't do it. We need to kind of control that. That needs to be within your local policy. So that's an example of local control. You have guidelines from the state. You can make it tighter. By all means, make it tighter, and especially for medication. We wanted to, we have a lot of school nurse coordinators. We want to encourage coaching of school nurse coordinators, mentoring, coaching. Those of you that have been around for a while, excuse me, I'm going to unplug my computer and replug it in. I'm at my mom's house because she's not been well. So it's just hang on a minute. I have to say this has been an unusual day. I'll just say it right there. So thank you for your patience. So I hope I'm charging. Thank you. Been an interesting week. Okay, so again, local state policy, very much different. Coaching program, if you would like to coach or mentor, we really want to encourage you to reach out to your neighbors. If you know a new school nurse coordinator, that's just come on. Hey guys, we know this is a tough year if you're a seasoned school nurse coordinator. I just can't imagine coming in, and we heard from the very beginning, we probably have at least 6, 8 at least school nurse coordinators in our Commonwealth. So this is a concern. This is showing leadership. This is something I want to encourage you to do, or reach out to us if you would like to be a mentor to someone, just to talk to somebody. It would really be really a great thing to do. And there's just a question that we want to see in the chat box. Normally we do new school nurse orientation and school nurse coordinator orientation during Summer Institute. And so we wanted to hear, and Joanne, correct me if I'm wrong, we wanted to hear feedback. She keeps me in line. What would you think to doing something online, like on a monthly basis, to kind of help new school nurse coordinators or new school nurses in that kind of an online orientation kind of process? We know that trying to get additional time carved out of your busy schedules can be challenging, but we really feel like the coaching and the ability to just chunk, you know, I'm looking at Glory. She's right in front of me on my screen right now, and Glory did amazing job with school nurse orientation for coordinators, for a new school nurse manager or coordinator. And the binder is about this big. It's huge. But to chunk it down would be, you know, to do this, even if it's over a year and a half, you know what I mean? It's something that's doable. It's something I can provide contact hours for the presenters as well as for the participants. So I think it's really important thing. It sounds like we're getting some positive stuff. I know a lot of us old birds here, I'm talking about me, are close to retirement age, and we just want to leave this in a good place. And so that's part of the invitation for emerging new leaders. It's part of empowering you to know, you know, to bounce ideas, to band together. I'm going to share with you that there are 2 school nurses. I'm just going to call them out, Colette Hokana and Alex Wilmer, that do from Spotsylvania and Stafford, that do a lot of things together. They're neighbors, and there's some, not crossover, but they have common, you know, common interests in that area. And so it's a shout out to them that they work on some of these projects for their schools together. policies, procedures, things like that. So, you know, I'm all for, you don't need to do something by yourself. So this is something that sounds like you would like to do, so we will pursue it. And the last thing I have on my part, and you're all probably yawning, again, we want to empower you all, and we have had some schools of nursing reaching out to us. In particular, you heard from Vicki Southall if you attended the Virginia School Nurses meeting 2 weeks ago, and the school nurse standout. And Vicki Southall, her community health students are creating a template, a monthly newsletter template that you can use. It's on Padlet now for back to school, and the October newsletter is ready to go. It's ready for your school name on it, your school division name, to use all or parts of it. And the focus is the flu. And this will be a monthly newsletter that her students can learn about the importance of community health, because they can't go to community health settings. And so this is one way that they're getting some of their clinical hours in. And so this will be available, and it's posted already to Padlet under back to school, under newsletters, and the monthly one is ready to go. If Robin, if you're on underneath my email signature, it should, well, actually it's in this agenda. It's a back to school Padlet for school nurses. It's listed under DOE. So check on that. It's also under my email signature, as well as Joanna's too. We both contribute to that. And now you're probably just sick to death of hearing from me. So I'm going to turn it over to my trusty partner. And you will get an agenda, you will get a recording tomorrow, and you will get the slides from this meeting today. So Joanna, take it away.
Thank you so much, Tracy, and thanks everyone for joining us today. And we appreciate all that you guys are doing, and we want to support you as much as we can. So please do not hesitate to reach out to us. And also with the newsletter template, just keep in mind that that's a good way to keep in contact with your families. It'll give you a kind of a point of contact for some of you that are virtually learning. It's a really good way to get it out. You can do it an email blast, or, you know, your website for your school. You could have like a little nurses corner, so it'll help you kind of reach out for those. And it's really nicely done. As far as the COVID dashboard, hopefully you guys have seen it. Used it a little bit. Just keep in mind, the most important thing is to all the information. You're not alone. So remember to reach out to your local health departments, reach out to your school administration, and do it as a collaborative effort. As far as the Virginia Department of Health algorithm, I really love that. I love that they took all of our suggestions and made this lovely school booklet, child care booklet. So please keep that in mind when you're using it. But also, if you have any questions, don't hesitate to email Tracy or myself within the next day, because Diane Williard, who has spoken to us before and has been on the previous algorithm call, is going to meet with us again on Thursday. So we could give her some questions ahead of time, and she's really looking forward to it. We've given her some great feedback. So please do not hesitate on reaching out to Tracy or myself, and we can get those questions, Diane, so we can get those answered for Thursday. But she's going to give us an overview. As far as the immunization report, today is definitely the 13th, because we have been experiencing just horrible issues with the IT department with the Virginia Department of Health. So please, you may just want to step away till tomorrow and go back, which I know is cutting it really thin on this immunization report. Right before this meeting, I tried to get on to do a few things and could not. So maybe during this meeting, they have fixed the problem. But keep in mind that the kindergarten and 7th grade students are for the immunization report. Instructions are on this agenda as far as passwords and things like you may need to help you. But I must apologize about what's going on. The website's down. Links to the Padlet aren't working today. The algorithm site's not up because all of it is tied to an IT glitch. So as soon as they get that solved, everything will be up and running. So I apologize. Hang in there, guys. Another thing we were talking about is the Summer Institute for School Nurses. I sent out a survey a while back. It should be in your email if you haven't responded. We've had good response, would like a little bit more. So feel free to go in and take that survey. And also there was a survey that was sent out for the school nurse shout out. We got great responses. So please, if you know of anything going on, do not hesitate to fill it out and send it back to us. I know things are changing daily and great things are being done. And so please let us know, because Tracy and I would love to know what's going on in your school communities. A couple of things we're considering for the upcoming School Nurse Summer Institute, based on the feedback that you guys have already given us, is the new school nurse orientation and the school nurse coordinator some basic training, which Tracy was touching on, but we're also talking about maybe doing that as part of the Summer Institute. Immunizations, as we're fully aware, things will be changing starting in July of 2021. So we're going to reach out to the Virginia Department of Health, the immunization folks, and see if they'll be more than willing to give us a little update on the new things for 2021, and maybe do some legislative overview. So those are kind of what we're looking at so far, among many other things. But like I said, please don't hesitate to fill out that survey and let us know your thoughts. As far as the MRC folks, I want to touch base with you guys. They are wonderful partners to have. They have been more than willing to help us during this crazy COVID crisis, which I think is wonderful. When we're about at our wits' end and can't figure out how we're going to do this as one school nurse in a school, or maybe one nurse over several schools, please keep in mind to reach out to them. We have got things in place for them to help you with hearing and vision screenings and maintain infection control, stopping the spread, helping you guys with that. But also they're trained to do the actual, vision part. Some of them are retired pediatricians. Some of them are retired school nurses that really want to help you guys make a difference and lighten your load. So please do not hesitate to reach out to them. Unfortunately, I'm going to tell you, I was really disappointed. I touched base Friday afternoon to see if I could kind of shine a light on this, and we have not had one single nurse reach out for hearing and vision help. Not one. And yet they have procedures in place, volunteers that are on standby. I cannot stress to you guys, it will help you tremendously to let them in. And I know some folks, school administrators are, toting a hard line saying they don't want any guests in the building. I would strongly encourage you to reach out saying that they're not guests, they're medical professionals that are trained in stopping the spread of COVID. They are trained in the mitigation strategies that will allow you to get your schools back open. So I really do want you guys to, if you can use them, please do, because they are there on standby waiting. And it's a resource that we're just not tapping. For immunization clinics going forward, I want to thank the folks that have done them in their areas. A lot of folks did drive-through clinics. Harrisonburg City Schools did. Thomas Jefferson District did. I know Henrico and City of Richmond did a collaborative partnership. I just want you guys to know that I'm sure there's more out there. I just haven't, please send me your data. Let me know what's going on. But I really want to let you guys know that it's a wonderful thing to reach out to your community like this, especially knowing that it's very difficult to get into the health departments. It's very difficult to get into pediatricians' offices. And so I'm impressed by the folks that took it before back to school. But remember, this can happen all year long. We're also working with the MRC folks to streamline the training process. A lot of you guys have expressed interest in becoming MRC volunteers because if you're a volunteer, it does help you with the liability part of these immunization clinics. It also helps you to serve your community because you fall under the MRC as opposed to your own insurance or functioning within your own school district or functioning within your own little clinic world. I want you guys to know that we are going to streamline that process. We're going to make it much easier. Jennifer Freeland's going to talk to us in November, on November 10th. She's going to do a 1-hour MRC mandatory training. You will get contact hours for that. The follow-up will be Janine Uzel, and a few days later on the 12th, and she's going to do Vaccinator 101 training, which is the training for Tdap, HPV, and the flu, and potentially the COVID vaccination when it comes out, when time comes for that. So I just want to let you guys know that we've taken this training and really compacted it down, getting it down into, very tight time frame, letting you take the post test on your own. You'll get contact hours for the entire experience. And it will allow you to be an MRC volunteer because I know a lot of folks are interested in doing it, but they don't want to commit to a lot of training. A lot of folks do not want to go outside of their school community, and they do not. You can, as an MRC, you can pick and choose what you want to do, when you want to do it. So if you want to just function in your school community, it's totally fine. So just please keep all that in mind that upcoming there is some training for folks, and we strongly encourage you, if you are at all interested in doing any immunization clinics for your school population, to please join MRC. And then we've got a professional development with Children AAP and the Children's Hospital of Richmond. We've got the mini conference on the 3rd of November. And so the registration link's there for you guys who are interested in, who have not signed up but are interested in participating in that. So we've got kind of a lot going on. I want to let everyone know too, the Virginia Department of Health, the school health website is on the agenda. We have really updated it. And so when you go in, there's going to be your plans and forms, there's going to be guidance, all kinds of things on there. So if you get a chance, feel free to peruse it. And then if you have any feedback, don't hesitate on shooting me an email. There are some things that are extremely dated. I'm aware of that. We have put various things to go up through the commissioner and the Department of Education to add on to that website. So kind of keep that in mind when you're looking. If something looks kind of dated, keep in mind that the last bit of information that's there is the most current that's been approved, but we are in the works of getting a new Virginia School Health Guidelines is going up through the commissioner now, and we'll go through the Department of Education. As Tracy's worked diligently on the asthma management plans, the anaphylaxis in the school setting, diabetic and medicine administration, all that stuff, as soon as it's approved, will be posted on the Virginia Department of Health website. So I just want you guys to know that there are some resources out there that hopefully will make it much easier for you. On that health site, we've got a tab for parents, we've got a tab for school nurses, we have a tab for administration. So based on what you need, there's a request form. So if you guys need flip charts or you guys need updated information, don't hesitate to go on there and ask for the most current, and we'll get it to you. A lot of stuff can be downloaded, and a lot of stuff is now on fillable forms. So hopefully that will help you out. And we just have a few questions from the field. And Tracy, do you want to take those questions from the field?
Go keep.
Oh, you want me to keep going?
Yeah, go keep on going. Yeah.
Okay, because I know we're running short on time, so I didn't know if you needed to come in. But as far as we've had numerous questions about records management, it always makes me happy that you guys are digging into those files, because that's where we find all the stuff that's missing that we need, like immunizations that haven't been completed, and I can't thank you guys enough, because that's just above and beyond, because it's so crazy. But as far as have reached out to record management with the Library of Virginia, all these questions from the field that have happened in the last few weeks, we've gone ahead, posted, and added a tab to the Padlet site. So you should be able to have this information at your fingertips. But one person wrote in about moving to an electronic file format and are no longer going to have paper files. And the Library of Virginia responded saying an electronic file is perfectly acceptable. And some school divisions are almost entirely electronic. And so you guys, that should make y'all breathe a little sigh of relief. And then as far as when we talk about vision and hearing screenings, medication administration sheets, and the scoliosis reports, they're going to be, would fall under school schedule for the cumulative health folder. So they need to be retained for 5 years after the student graduates or leaves the school system. As far as injury reports fall under student accident/injury reports, and they are to be retained and not destroyed till after the student's 20th birthday. And then is it still 5 years for clinic health related reports? If there's any treatment that would fall under cumulative health record, or if it's just a record of the student visit with no treatment information, then it can be covered under clinical records, and retention is 1 year after the academic year. And employee items such as medicine administration training, EpiPen, or other training. Training for employees doesn't involve a formal certificate or qualification, falls under training records, and the retention is 3 years. So hopefully that will help you. If you guys reach out to Tracy and I, which is wonderful because we love to hear from you, but there's 2 folks within the Library of Virginia that can help us. Emmeline is our main person because she handles the schools. Chadwick Owen is over top of her, but I just wanted to put that out there. And a lot of times we'll send it out, but it may take a couple of days to get back. But if you're in a terrible hurry, you may want to email them directly and let them know that it's an urgent request. And then one thing we have as far as question from the field that's not a record management, does VDOE have a protocol or policy for a student who is found or suspected of being unwell by school staff during virtual learning? So that would be like the teacher noticed in the classroom under the virtual little windows like we have now. On the screen, she's like, this one student just doesn't seem well, doesn't look well, doesn't appear to be themselves. What Virginia Department of Education has requested is that each local school division develop some type of plan to notify the parent or guardian, just the same as you would on in-person learning. If a teacher has a concern, they need to definitely notify the parent just as they would if the student was in the classroom. So I hope that helps you guys. It's 4:01. I'm sorry I'm running a minute late. I'm going to hand it back over to Tracy to shut it down, but I just want to thank you all for all that you're doing and let you know that we're here to support you. We're so proud of you guys because you guys are just rocking it. And so we just want to let you guys know that, your hard work has not gone unnoticed. The school nurses themselves that are not coordinators are saying our coordinators are awesome. They have the best attitude and they're helping us all the time. So we want you guys to know that you are well loved, even if you don't feel it. And we love you tremendously. So I'm gonna give you back to Tracy.
Thank you, Joanna. So again, we've condensed a 6 to 7 hour school nurse coordinator training into a very short period of time. As I mentioned, this is you know, 2 hours. Alicia was saying we need an intermission to stretch our legs. We're not going to be doing that today. Learning some more. We're ending the meeting here in a few minutes, but we certainly can raise this at future meetings and have somebody from the Library of Virginia speak to the group about records retention, because that was always an area that I myself, you know, struggled with. So I get it. So anyway, we've given you a smattering of information. It's always changing, you know. I appreciate Susie coming on in. The idea of, you know, testing, possibly testing in a school, it causes concern because we're a school and we're not, you know, a medical facility. What I did gain from that information is that this is not even in the realm of discussion for the foreseeable future until they can figure out how to operationalize and target areas. And I suspect there would be group assistance from their teams in order to do this at locality. So, but I want to thank you. You're doing a great job. We've been hearing from you. We know that you are working hard. I want to echo those comments from Joanna. And please let us know what you need, what you want from us, and we will try to deliver. We're trying to get it straight. Just when we feel like we can take a deep breath, we you know, something else pops up, and I know you all feel the same way. So anyway, but Cindy Knight's giving me an evil eye there from Green, but anyway, she said she's not. I'm calling her out. I'm just teasing. Just had to be sure she was paying attention there. So again, on behalf of Joanna and myself, I want to welcome our new school nurse coordinators. I hope we didn't scare you. I'm going to be sending out, it looks like you want to know who your neighbors are. So we'll be sending you an alphabetized list of current contact information. If we screwed up, if we messed up or misspelled or whatever, please let us know. Because we want to be sure we've got these updated lists. You know, we don't get notified usually of changes in personnel, and when you have, you know, 132 school divisions and a whole bunch of private schools, entities across the state, is kind of hard to keep up. So anyway, thank you again. Have a great day. The rest of the week, these weeks, if you had Monday off, and not many of you probably did, but if you had Monday off, we know these short weeks are brutal. We pay for that day off. So anyway, so thank you again. Our next meeting will be in December, and we'll have more information to share with you then. So thank you all. I'm going to end the meeting now. Thanks again. Have a good one. Bye-bye.